croeso cynnes I Sir Benfro a Bernardine Rhys yw I a Cadeithuriad Iechyd, Bwrdd Iechyd. Fi yn also a dysgu Cymraeg. Anyway, thank you ever so much for coming to this extraordinary meeting. Today is a long session, and rightly so, on the basis of the future of the organisation of care across the Hywel Dda Health Board. I want to first make a few domestic announcements. You will see that I'm coming through a microphone, and for members of the public this must be a joy. To those members of the public who follow us around on a regular basis and have trouble in listening to us. So you're very, very welcome. And just to remind everybody that we're also streaming today, and thank you to Pembrokeshire Local Authority for the facility and for all the help that we've received to be able to get to today. But it does mean that we have to think differently as a board. And that is that you have a microphone, you need to introduce yourself before you speak, press the green button, speak, switch it off. And I'm really sorry, it's been drilled into me so many times today that I have to share that same position with you. So I want to start with some apologies. John Gammon and Julie James, who are in the sun, and I know that at least one of them will be using the streaming to listen to us this morning. And Jonathan Griffiths, who actually is our new Director of Social Service representative from Pembrokeshire, and Jonathan's given his apologies for today. I suppose, before I start, we have two new board members who are here purely for observation today, and what a day to come to observe. So very welcome Anna Lewis and Owen Burt. You're sat with people who can help you and navigate you through a board meeting. But I will say, both for the public and for the members here today, this is not a normal board meeting. We're normally not this big, and we welcome sincerely those members of our clinical teams and those members of our design teams who have put together today's programme. I'm not going to go into the detail of the programme, but what I would respect is that both the audience and the board listen to the presentation. There are a numerous amount of technical papers that support the presentation that will be out, and then as a board we will have the opportunity for questions. I remind the public that this is a meeting in public and not a public meeting, so while I'm delighted that you are all here to listen, we really need to have the discussion. The direction that I give to the board is that we are not here making any decisions today. Today is purely about the options that we will agree, and we need to agree, having heard the clinical arguments for the options, to then go out to consultation. So we're only agreeing that the process is robust, that we've signed off on the process. This will be the first time for us that we will have heard this presentation in its entirety, and it will be the first time that we understand as a board the implications of the options. We will have seen bits of it, we will have contributed through listening and testing, but we will not have seen the detail that we're about to be exposed to today. And on that basis, it's whether that detail is the appropriate level of detail and process that's been undertaken that will go out to consultation. And that's all I think I'm going to say today, at this juncture anyway. So I'll now hand over to the Chief Executive. Please can I remind you to speak, switch the button on, switch it off when you've finished. And don't forget to say your name. Thanks. Steve?
I know better than to disagree with the chair, so I will say my name is Steve Moore. I'm the Chief Exec of Hywel Dda University Health Board, and I press the green button. Just to add my welcome to today, this is a really important moment for the board. Firstly, to express my gratitude as well to Pembrokeshire Local Authority for allowing us to use this really great venue. It's both important given the number of people in the room, but also because of the the issues that we're talking about today, actually an opportunity to engage through the miracle of technology with hopefully a wider set of people who can listen today about the sort of debate that we're having. So I'm very, very grateful for that. This is an important day for us. There's been a huge amount of work to get us to this stage. However, whilst I look the team in the eye in front of me, to also say that actually this is the start now of a really important conversation for us about the future of healthcare, having done all that preparation. The NHS does get a lot of coverage, and I think in recent years we've seen that coverage be really quite negative about the challenges we face. Actually, today for me is about setting out what I hope will be a very positive story about the future of healthcare, about how we can improve what we've got, make it better for the local population. And I think it's a real privilege to be a member of the board on a day when we're able to start this conversation with that aim in mind. I'm also grateful for all the work that has gone into this, this process so far, both from the team that have run this centrally, but also looking around the room today at all of the clinicians that we have here, the huge amount of clinical discussion that's gone on to get us to this stage, and the genuine open desire to think about how we can improve services for our patients on everyone's behalf. So I think, a real culmination of a huge amount of work. I would also say, though, given that this is the start of a conversation, that we all know we have the humility to recognise that actually we may not have thought of everything, that other people's perspectives are important on what we're planning. So this consultation, I hope, will be a genuine, open-hearted discussion about the current system, about the trade-offs that we currently face, and actually how we can make that better, but also ensuring that for those who may be challenged by some of the issues that we're raising, that we really listen to that and we think very deeply about how we can make that better. But I guess at the end of this, we have to also recognise that as a board, we will need to finally make a decision, having heard all of the debate over the coming weeks. Because what I hear from our clinicians every day, and we'll hear some of it today in the presentations, is the status quo can't carry on. We know our staff go above and beyond in the winter, but actually across the year we see that happening. But we know it's getting tougher every year. We do have to do something different. We can't stay as we are. And I'm hoping that when we come to the end of this consultation, we'll be able to describe something which is a very positive story about actually how we can deal with some of those challenges and make it better for the whole population of Hywel Dda. So on that note, and without wishing to steal any thunder from the team, I think we're going to hand over to the medical director.
Thank you very much. I'm Dr. Philip Claw. I'm the Medical Director and Director of Clinical Strategy for Hywel Dda University Health Board. Thank you, Steve, for handing over. Look, this is a huge moment for this health board and also, most importantly, for our public and our staff. And we know that health and care services affect each and every one of us, our families, our friends, and everybody we care about who live in this area. The decisions that we make will affect not just the people who are living now, but also the generations to come. They are of that magnitude, and we need to remember as board members that there are well over 400,000 people relying on us to get this right. I think that's why we've got doctors, nurses and therapists from all around Hywel Dda, from all sorts of different services, from across our geography, who've come here to say publicly to the board and talk about why we need to change and how we believe we can make things better for our public, working with our partners, and that we recognise at this moment that we need to go out to consult with our public to hear more views from our public and staff. So with that, I'm going to hand over to Dr. Mynir-Jones to start the presentation. You'll hear from lots of people, but Dr. Mynir-Jones is going to start us off.
Bore da, Dr. Mynir-Jones ydw I. I'm the clinical lead for Transforming Clinical Services programme. I'm a GP and I'm here with my clinical and staff colleagues on this monumentous day for Hywel Dda. We will be taking you through the programme to date and the incredible opportunity we have to completely transform our health service for our future generations.
In our presentation today, we will take you through the Transforming Clinical Services journey and how we will achieve our ambition to be a population health organisation. We're going to take you through phase 1 of the programme, which we call the Discover phase, and how this has established the foundation for the proposals that have been developed, including building the case for change, our listening and engagement exercise last year, the big conversation, and the resulting emerging models. The work in phase 2 of the programme we will also talk about, which is the design phase, which has resulted in our big NHS change proposals, including a new model for our community services and support, and 3 proposals for our hospital services, which is underpinned by a broad range of technical work to support the proposals that we'll talk about today. We will describe our proposed approach to consultation and share a range of materials which will enable us to reach a wide-ranging audience during the consultation period. We will then confirm our recommendations to the board.
As an organisation, we aspire to work collaboratively with our partners in local authority, WAST and communities, including our carers, to develop an integrated social model of care, moving away from our more traditional biomedical model. The social model recognises that health is everybody's responsibility, and only by rebalancing the relationship between patients and professionals, the citizen and the state, will we achieve a sustainable system which is fit for our future generations. We need to focus more on care closer to home, wrapped around the patient, and deliver a high-quality, safe service with equitable outcomes across the whole of our area. We know we currently have a 10-year age gap in healthy life expectancy across different parts of Hywel Dda. This is just not acceptable. We want to do better. Our workforce is our most valuable asset, and we currently struggle to both recruit and retain high-quality staff into our area. Much of this is down to services spread so thinly across our current hospitals, with increasing reliance on temporary staff in our hospitals, our struggling GP out of hours, and not forgetting our fragile primary care. More of the same is simply just not enough. We want to build a resilient workforce that has the flexibility to work across the whole system, with new roles to help manage the increasing complexity and ageing demographic of our future population. Shifting our focus onto prevention and self-management, we feel will help to reduce demand on our acute services and provide significant opportunity cost savings that could be further used to invest into our communities. And finally, as you will see with the following presentation, we aspire to make people and their families at the heart of our decision-making. It's about what matters to me and not what's the matter with me. Hywel Dda is in targeted intervention. We have both financial and clinical sustainability concerns. We believe that transforming clinical services gives us an incredible opportunity to redesign our services with our public and our staff. The underpinning principles of all these legislations have considerable synergy with transforming clinical services, with a focus on prevention, collaborative working with our partners, and providing a framework for integrating health and social care. Part 9 of the Social Services and Wellbeing Act in Wales introduces a duty to work collaboratively with our local authority partners, and also includes a requirement to establish a regional partnership board to drive integration, innovation and service change. The Act focuses on supporting vulnerable people within our communities to maintain their health, well-being and independence within our communities. When we started the programme, a little over 10 months ago, these were the questions that we felt were key to build on. Need. What is the community requirement for health and social care? Quality, what is it that we need to improve? Accessibility, how do we optimise care for our patients? And how do we maximise value? And sustainability, how do we provide services that are fit for our future? I've put this slide up here because you'll see these four words on every slide. Safe, sustainable, accessible and kind. They were born out of meetings with our senior clinical leaders over the preceding 18 months as guiding principles and absolutely underpin all the work that we've been doing to date.
Apologies, I didn't start well. I should have introduced myself. I'm Libby Ryan Davis, Transformation Director, so that was a good start for me. The Transforming Clinical Services programme launched formally in June of last year. Our programme is clinically led with a key aim of setting out our strategic ambition and the long-term future for the health and care services that we provide locally. The programme is focused on keeping people in our communities healthy and preventing ill health, keeping people away from our main hospital services unless necessary, with care that is closer to people's homes. The TCS programme has been organised into 3 distinct phases. Phase 1, the Discover phase, involved developing and presenting the case for change and a clear baseline for our services from where to begin, including the development of 3 clinically led programmes for community care, planned care and urgent and emergency care, who explored services locally, nationally and internationally to confirm emerging models of care. Alongside this work, we undertook our listening and engagement exercise with our staff, public and stakeholders called The Big Conversation, to have an open and honest conversation about what good would look like in community planned and urgent and emergency care. This resulted in an output report that was presented to the board in November last year that outlined the emerging models that the clinicians wanted to progress into more detailed design. Phase 2 of the programme, which commenced in December last year, involved taking all of what we learnt in the Phase 1 of our programme and developing a long list of options which were refined through a large number of challenge and testing events with staff and key stakeholders. We invited a range of people to score our final long list of options against a set of criteria which we based on what we heard during our conversations in Phase 1. Which enabled us to confirm the proposals for consultation that will be presented today by our clinicians. All of the work in Phase 2 is underpinned by the work of a number of key enabling groups such as finance, workforce, estates, digital and population health to enable us to complete an initial level of modelling to understand the impacts and opportunities of the proposals. We will move into Phase 3 of the programme, our Deliver phase, following analysis of the consultation outputs later in the year and agreement on the recommendations to the board on a preferred model and strategy for the future. The board have a number of key responsibilities today in considering all of the information that is presented to them. These are set out within the Welsh Government guidance for engagement and consultation. The board must be satisfied that there is compliance with stage 1 of the consultation process, and this is the formal engagement and options development stage. Also, the consultation plan is inclusive and meets the guidance in relation to public consultation, and that the consultation materials that you'll hear about today give sufficient detail for consultees to be able to contribute in a meaningful way. Only when the board is satisfied should it approve commencement of stage 2, the formal consultation.
Bore da, I'm Ros Jervis, Director of Public Health for Hywel Dda. Now I have a few moments to take you through some slides that describe our thinking and the journey we are on in terms of aligning this process with the development of a long-term strategy for health and well-being for the population of Hywel Dda. So with an eye on the future, making that all-important difference in improving health outcomes for our children and our children's children. The opportunity the Transforming Clinical Services programme presents is really significant in terms of making this happen and realising our ambition for population health. Now, I'm sure most of you will have seen my triangle slide before, although it's had a bit of a makeover recently. I initially used it to describe the shift needed in terms of mainstream investment in prevention and supporting local people stay well. I now believe it represents more than that. For those delivering health services like ourselves, putting population health at the heart of what we seek to change for the better will also need a shift in culture. Moving from a sole focus on illness and the diagnosis and treatment of disease to one of helping people stay well is going to require a change in mindset and behaviour, not just in relation to the choices made by all of us, actually, in terms of the way that we live our lives, but also that of our workforce in the way that we go about our day-to-day business. So, starting with understanding the needs of our population, and that's a really good place to start, especially when developing services fit for the future demographic of Hywel Dda. And we really supported well in the assessments of need that we had available to us, including those that took a look at specific conditions, to others with a much broader perspective in terms of the social and economic determinants of health and well-being, which we use to develop our local well-being plans. We also have needs assessment that cover health needs from a local, regional and national perspective. And if you are interested in any more detail, please can I refer you to Appendix 14, the technical document that provides information on understanding the needs of our population. You will hear shortly from my colleague about the health and wellbeing challenges we face. But just in terms of thinking about a different approach and looking for greater investment in prevention and early intervention services, a good place to start would be the conditions that are causing people to die prematurely, causing significant levels of ill health and often multiple and complex needs. I won't go through that list, but there are no real surprises in there: heart disease, common cancers, respiratory illness and diabetes, with common contributory causes such as smoking and obesity, all very much preventable. And change isn't easy. Presenting a list of needs doesn't automatically lead to effective action. We have to plan together with our partners and learn how we can change and adapt our services to reach those who will benefit most, ensuring that this is done on a scale we need to impact on health, and that must be population-wide. Our approach, therefore, cannot be internally focused. It needs to be fully integrated with all the strategic ambitions of the Health Board and its partners. It must lead to that all-important culture change, doing things differently, including the development of the concept of wellness services. Now, the big news for me through all of this is that the delivery of services will be predominantly through a community model. And being in a position to shape community networks that enable a social model for health and care to deliver support and services that matter to local people presents us with a huge opportunity. This brings me back to my earlier point about a shift in mindset and the development of services that seek to support people stay well whilst remaining in their own homes and within their local communities. Now, my last slide really presents the art of the possible in a way. Holistic services that wrap around strong clinical, primary and community care services, which all will encompass the things that matter to everyone, provide support across a broader spectrum of issues that impact on our health and well-being, the maintenance and development of social connections with our families, friends and neighbours, and maximises the use of the natural resources we are so blessed with here in West Wales.
Why do we need to change? I recently posed this question to three of the medical, Andrew Burns, consultant surgeon and Withybush Hospital director. I recently posed this question to three of the medical secretaries at Withybush, and a common response was the distance they needed to travel in order to access specialist services to Glanwilly, further afield, that were not available locally. And this problem is more pronounced for those who live in coastal areas. And I think this very much illustrates that our current clinical model, our service configuration, really does need to change if we are to provide good quality future care for our patients. My colleagues will now expand on that theme, but first of all, I'd just like to, the following video is the view of one of our consultants in A&E, Dr. Jeremy Williams.
Robin Goschel, Hospital Director for Prince Philip Hospital and respiratory physician. There are many challenges that face the NHS within the UK, but some are very specific to the Health Board, and they're all interlinked. Although they seem separate in their own entity, they are linked. There are advances in medicine over the last 10, 15, 20 years, and that's led to patients living longer, which actually it's great. We'll all say that's a great thing, but what it does, it leads to greater burden of illness, and it also means there's greater demand on our front door and within the community as well. We are, as separate hospitals, finding it very difficult to meet that demand, and we can see that from the 4-hour waits and the number of patients sat in A&E, as described in the video, for example, for 50, 60 hours, which is simply unacceptable. It also has an increasing strain on our workforce, which is depleted. There are many rotas across the Health Board. Many of them are threadbare, and when we try and fill them, we fill them with locums, and the wards are filled with agency nurses, which some of can be good quality doctors, but many are of variable quality, hence they're not in training posts or in substantive posts. And that ultimately leads to poor quality care for the patients. And this is delivered in some facilities across the Health Board which just aren't up to scratch. And that has impact on terms of retaining good quality consultants, but even attracting. And suddenly you see this big spiral where we're spiraling down into a period where we just can't sustain the services as they are. This has led to inequality of care in the more rural parts of the Health Board, and this has led to what Mynir mentioned about a difference of 10 years in healthy life expectancy. My parting comment on this is that although there are real pockets of excellent care, and we mustn't lose sight of that, but the totality of these challenges are not only failing our frail adults and some of our frailer paediatric patients, but it means the Health Board itself is becoming increasingly frail, and increasingly it is unsustainable. And there is no doubt change has to happen.
Bore da. I'm Mary Edmonds. I'm a cardiologist and the hospital director for Glangweili. I also want to echo the points that my colleagues have made about the case and the need for change. The NHS was set up about 70 years ago, and it's been an amazing success, and it's transformed the lives and the health of the population of Britain. But in a way, we've become victims of that success. People are living longer, which, as Robbie's pointed out, is a wonderful thing, but those people are living with more complex needs. Previously, you'd meet an 80-year-old and perhaps they'd have one problem. Now they've got several problems. And the population is growing older because of the success of the NHS, but they have more complex needs. And in the rural areas that we live in, young people often choose to move away, so those carers that were previously available to look after their families, the extended families, have left, leaving large areas of population that are isolated and elderly. And because of the rural population, they often find it difficult to access our health services. And our health services have been focused on the hospitals, and there's been less focus on the population needs out in the rural areas. And the hospitals, which is what we are predominantly interested in because that's where we work, are old, they're beyond their life expectancy. Many of our services are falling apart. There hasn't been sufficient investment because of the financial constraints. And it's difficult to provide high-quality services that our population in 2018 deserve. And when we want to improve services in one area, we have to improve services in 4 areas. So instead of getting 1 CT scanner, we have to buy 4 CT scanners. Instead of 1 MRI, we have to buy 4 MRIs. And it makes it very, very difficult to develop any sort of service which is suitable for our time and age. So we need to change. Thank you.
Hi, I'm Carol Llewellyn-Jones. I'm a chest physician and I chair the Medical Staff Committee for Carmarthenshire. We've already touched a little bit on the workforce issues, and my brief is just to expand on some of those problems. I've been in the Health Board for 17 years, and I have seen in more recent years a growing problem with our recruitment. We have a growing problem with retaining the staff that we do recruit, and we have a growing problem with the number of vacancies that we are carrying. We also have, myself included, a growing number of our staff members who are reaching retirement age. And we are concerned about what will happen when those of us that are of that age do finally leave our employment. The recruitment problems and the number of vacancies affect all grades of staff. It's not just consultant level. We have problems recruiting and retaining junior staff, particular problems with middle grades, and in key specialist areas, we have particular problems, such that we have some specialist consultants having to travel to cover maybe 3 or 4 hospitals. And we also have, as we have heard already, large number of patients who are having to travel to access the specialist services that they require. Mine has already said that we are spread too thinly. We are spread far too thinly. We have specialist staff trying to cover far too many hospitals, and that is a stress on our staff. We have others then who do not see enough patients to actually maintain their expertise and develop further expertise in a particular area. We are struggling to keep 4 medical on-call rotas going, as well as 3 surgical rotas. And what we really need is a critical mass of staff so that we can provide all the specialist services that we need and develop further expertise in particular subspecialist areas. We've already heard that we rely heavily on temporary or locum staff. Some of these are highly skilled, but they are very variable. And even if they are highly skilled, they do not come from our background. They're not of our health board employ. They are not part of our culture. And, of course, it is a very expensive way of keeping rotas running. Configured as we are, we struggle to maintain the rotas that are modern, flexible for today's working needs, and also give the required training that is needed for our deaneries. This is a problem that I have seen in recent years. It's growing year on year, and we cannot continue in this way. Our rotas will fall down. We have to change.
Andrew Burns. I'm sure that the board is only too aware of our financial challenges. The health board budget is around 800 million and we're already overspent, and this is increasing. Yet money is needed to support, pay for temporary staff, to support fragile medical rotas, and to ensure we maintain safe services. Money is required to maintain ageing and outdated and expensive facilities, many of which are duplicated across the 4 sites. But this money could be better spent. It could be better spent in the community, in general practice, keeping patients healthy, keeping them away from hospital. The money could be better spent on innovative, high-value, evidence-based treatments. This is not happening. Things need to change. This is not acceptable.
Bore da, Helen Annandale, Head of Physiotherapy across the Health Board. If I take you through the Discover phase of the programme. So phase 1 of the programme focused on setting out the case for change, exploring the models of care locally, nationally and internationally, and also looked to develop the emerging models that we would take forward so that we looked at what good looks like. The timeline demonstrates that we've run the programme from June to November 2017, and then an output report was presented to the board in November 2017, outlining the models to progress into the more detailed design phase of the work in phase 2. Libby mentioned the big conversation. So in June, the Health Board meeting, we launched our 12-week listening and engagement exercise, the big conversation, where we talked to the public, staff and other key stakeholders. The Case for Change engagement document developed was circulated to over 4,000 stakeholders across the Health Board. We also had over 80 different events during this time where we listened to a wide range of staff, public and stakeholders. Over 50 different forums were undertaken to ensure that we listened to a broad spectrum of views. The Health Board commissioned the Opinion Research Services to undertake an independent analysis of what we heard, and you have this report in your papers. What we heard was grouped into themes, and we used this as part of the foundation of our development proposals. If I take you through just a few of the themes, for many, quality of care meant effective, timely appointments as close to home as possible. Looking at where people received care, there was significant support from our public, staff, stakeholders for integrated one-stop shops within the community. Some people would travel if it meant they had increased access to specialist care. With regard to resources, there was overwhelming support for more community services by creating a flexible, multi-skilled, multi-professional workforce. Specifically about estate, there was concern expressed about estate, especially the Glangwili estate, as it was considered not fit for purpose, especially going into the future. And then finally, there was widespread support for easily accessible electronic records that could be accessed by many.
So listening to our staff, service users and the public, we also heard, in relation to community specifically, there was a general view that people should be encouraged and supported to take more responsibility for their own health. This, it was felt, could be achieved by increasing knowledge of self-care and how to manage health conditions, and by raising awareness of alternative services available, along with a greater focus on prevention. Feedback showed widespread support for receiving healthcare services in the local community rather than in hospitals, with particular enthusiasm, as Helen's already mentioned, for one-stop shops, or hubs as we're calling them, where people can have multiple health and care needs addressed under one roof in their local community. Generally speaking, there was a consensus of opinion that people need better access to primary care, particularly through reduced waiting times and easier, more flexible ways of making appointments. In relation to urgent and emergency care, we heard, as has already been demonstrated in the video, concerns with the adequacy of the emergency transport system, concerns that A&E waiting times are currently unacceptable, wide acknowledgement that many people could use alternative services more rather than attending A&E as the default place to go. There is a need to raise awareness and accessibility of alternatives. It was suggested roles of other urgent care staff could be explored. For example, paramedics could have extended roles to help cope with the demand. And accessibility was a key theme, with suggestions including the provision of more urgent care facilities, such as walk-in centres and minor injuries units in the community. In relation to planned care, people told us that waiting times for planned operations are too long and there are too many cancellations. A general theme was that the current unreliability of these planned care services is causing distress for individuals, their families and carers. There was considerable support for separating planned and emergency services and for creating a dedicated centre of excellence for the former. General consensus was that most people would be willing to travel to receive specialised planned care at a centralised site if they were guaranteed a reliable, quality, timely service. There was a view that if people had to travel for treatment, there needs to be adequate transport available, as well as rehabilitation services closer to home, with clear care pathways to get people home from hospital as soon as possible.
Alan Williams, GP. We're now going to look at emerging models of care. This phase of the process was developed through 3 clinically led groups: a planned care group chaired by Mark Henwood, an urgent and emergency care group chaired by Jeremy Williams, and a community care group chaired by Sean James. These groups took into account all the conversation and engagement exercises we've heard about. They took into account new and emerging models of care from around the world. They took into account the board's current challenges and workforce and others, as we heard about. And they took into account professional and clinical opinion from within the organisation and within the boards. To start with, we're going to look at community care first, because it's the most important bit. And to do this, we have a hard-working GP from Tregaron on the video.
About 5 years ago, I was losing weight, and I stayed my door yellow and things like that, and then I was taken up to Bromley's Hospital. And I was there for 3 weeks, and after the 3rd day, they came and said I got lupus, which affected my liver and my lungs. I'm Dr. Sean James. I'm a GP in Sharon Surgery. I'm clinical director for primary care in Ceredigion, and I've been involved in the Transforming Clinical Services programme for Hywel Dda. hardly walk further than half a mile, and that was it. Since I've had a 7-week Viper course in the whole in Tregaron, I found that really helpful, plus the exercise. It's near home, and it's nice to have something like this in the community. It's made a hell of a difference to my life. I even rode my mate's horse about 4 weeks ago. I was really upset when I had to sell the horse. There was a few tears. I just can't explain how nice it was.
I think this is not about buildings, really. This is about delivering networks of services to people in their communities. But the services that they get are not going to change in a negative way. They're going to get more rather than less in the future.
I'm Dr. Sean James from the video. As part of our community care group, we researched examples from across the world and the UK of good systems of community care. And when the slide comes up, you'll be able to see some of the examples that we looked at. In particular, we looked at healthy prestatyn, we looked at the primary care home model, and also the Canterbury model from New Zealand. So we drew from all these models the things we felt that were most important and had the most evidence behind them. As well as that, when we developed our common themes, we had all the information from the big conversation and what was important to our public. So the common themes that came out were that the models needed to be population-based, so based on our existing localities, really. That there needed to be integration of health and social care services as well as third sector services. And then we needed a non-medicalised model, because at the moment, one of the few options that we have sometimes is hospital admission, and there are no other alternatives available to us. So we needed to use our community assets in a stronger way, and examples that we've had already locally are social prescribing, use of community groups in different ways. We need to wrap services around primary care and around our patients, really. What we also felt was important that we developed the concept of a single point of contact or a single point of access. And because our systems at the moment are so complex sometimes, that there needed to be care navigators to help direct our public and our patients to the most appropriate services that they need. We also felt we needed enhanced out-of-hours services, and that a lot of our services needed to be 7-day and 24/7 services. So all this work led us to develop some common collective vision, really, for the future of community care in Hywel Dda. And we came up with a statement that we believe that health is co-created in our communities through family, friends and neighbours. And I think that's really important for us to emphasise. In this new system, people would be empowered to take control of their own health. Informal carers would be recognised and supported, which doesn't always happen. And the workforce, we've heard about the importance of the workforce already, that the workforce is fulfilled and happy. And there's integration across all professions and also across all organisations. And the care needs to be delivered in the right setting, at the right time and by the right person. Access is very important, because as we redevelop our system, we don't want to disenfranchise anyone. So access needs to be equitable and easy to navigate. And we also need to recognise and develop our existing community assets and not redevelop what's already there. And the existing networks are already in place, and we need to maximise our use of them, and also maximise the use of technology to the benefit of staff and our patients.
Jeremy Williams, A&E consultant and clinical director of unscheduled care. I've been a consultant in the health board now for 21 years, and there have been a number of previous efforts to change healthcare in this part of the world, unsuccessfully, unfortunately. But I feel that the process that we've gone through this time has been far more robust, which will hopefully enable significant change, which definitely is required. We've looked across the UK and internationally from Luton to New Zealand, and from South Devon to Scandinavia. And we tried to look at common themes of urgent and emergency care systems which have actually proved to be effective. These are some examples. There are many others. I think it's fair to say that when you are very injured or very sick, you will benefit from seeing an expert in the field as quickly as possible. We need more senior clinical decision makers at the front door. We frankly fail miserably on this currently. There are only 4 substantive consultants in emergency medicine in Hywel Dda across the units, and there should be 4 in each unit as an absolute minimum. So patients are not getting the best care that they could over the 24/7, 365 days of the year. We need to manage frail and vulnerable patients holistically. There are many more frail and vulnerable patients in our system than there ever has been in the past. And we need to manage their physical health, their mental health, and also obviously take into consideration their social care, so that we can truly manage the patient holistically. We need to actively manage these patients once they're admitted to hospital through the whole pathway. And too many patients currently are languishing, frankly, further decompensating. So they come in frail, and we potentially are sending them home more frail because they are in hospital too long, because there is a disconnect, whether we like it or not, between health and social care. And that has to improve. We need to consider all potential acute admissions for ambulatory emergency care. At the moment, A&E doctors frequently admit patients, especially out of hours, because frankly that's the only avenue open to them. There should be other avenues, there should be better avenues, and I think that the vision of the transformational process will allow that to be in place. We should prioritize activities to achieve the earliest possible discharge of patients, and further sort of integrate and coordinate the works of local health and social care. We need to look rigorously at schemes to prevent admission and certainly to prevent early readmission to hospital. These schemes need to be selected, properly designed, and rigorously evaluated. Patients often present to hospital because they have an acute exacerbation of their chronic condition. So that if those chronic conditions could be possibly better managed in the community, then it could prevent that acute exacerbation, bringing them to hospital in the first place. And lastly, we really need to separate emergency care from planned care. Currently, emergency patients will take the place of patients who are waiting for an elective operation. Those patients have worked themselves up. They've been told they're going to have that operation, and then at the last minute sometimes, through nobody's fault, that operation has to be cancelled. We wouldn't like this ourselves, and we wouldn't wish it on our patients. So we need to separate emergency and elective care, and I feel that the transformational process will allow that to happen. Emergency and urgent care often makes the headlines. People are interested to know what's going on in A&E departments. A&E is actually a good brand. People know that if you go to A&E, you will be seen eventually, so that they often pitch up. And we need to better provide for their needs out of hospital. Even the Queen, the bottom left there, the Daily Mail makes it look as though the Queen feels as though you shouldn't go to A&E too often, so that's by royal appointment. There are many, many examples of good work going around the UK, and frankly, the system is broken in Hywel Dda, and it's broken elsewhere as well. But I feel that we have been able to, we've got this one time, possibly, opportunity to make significant change. And I feel that we must grasp the nettle at this point.
Thank you, Jeremy. My name is Mark Henwood. I'm a consultant surgeon and I'm the Clinical Director for Scheduled Care in Hywel Dda Health Board. So we in the Planned Care Group, as the other groups, looked nationally and internationally to see if we could identify the best models of care that we could introduce in West Wales. And what stood out for me was that there was no one model that we could simply copy. We were able to identify good practice, but there was no one model that we could easily transpose to West Wales. But what was really pleasing to me was that the answers to all of our questions were looking us in our face, and it came from our patients. Through the big conversation, our patients told us how our model should look in the future. And a simple summary of what our patients want, and I'll read it out, is that they want a patient-centered experience of elective procedures and surgery where referral to recovery is right first time. And I think it's fairly clear that it's not right at the moment. And what's the detail of what our patients want? So they want no unnecessary hospital visits. At the moment, we are bringing patients to hospital repeatedly when a lot of this could be provided in different areas, and you've heard the concept of hubs that we would like to develop. Planned procedures should, of course, occur as close to home as possible, and there's a lot currently that we are doing within the hospitals that do not need to happen in hospitals. But I feel it's vitally important that I dispel a myth that has been propagated. Patients are absolutely prepared to travel for care. But if they are to travel for care, then we must be able to guarantee them and give them promise that they will have that care on that day, and that they will be travelling to a high-quality environment, and that they'll be treated by compassionate and well-trained staff. Patients don't want to stay in hospital longer than they need to, so we must be doing as many procedures as possible on the day and sending patients home. Unfortunately, over many years, we haven't been able to invest in our day case services. We need to at least double the number of day case theatres we have in West Wales. We've got to schedule operations effectively. It's got to meet the needs of the patient, and they've got to have the operation when it suits them, not when it suits us. We must have timely and appropriate preoperative assessment, i.e. that must happen close to home, and it can happen in hubs. It mustn't happen as is happening now many, many months before people's operation, which means that when they do come for their operation, they're not prepared. We must contact patients appropriately to answer all their questions and make sure we reassure them when they come for their surgery. Our theatres are staffed by very, very hard-working staff, I can assure you. But because of difficulties in recruitment, and because we try to maintain surgical services across all of our sites, our surgical services are not in any way as efficient as they should be. We also have an aim that we want to be able to prove to everyone the quality of our service. So you should be able to go on our website and see exactly what we're doing and how well we're doing. So, we now have a vision for the future, and again we'll read out where we got to after many, many meetings. So this is where people are empowered to self-manage their health and well-being, and when needed, have equitable access to safe, sustainable and kind care delivered as close as home to possible. Patients must be able to get the right treatment they need at the appropriate time and given by the most appropriate person. They must have appropriate outpatient appointments and preoperative care close to home. The majority of patients don't necessarily want to come to hospital just to see a consultant. A lot of outpatient activity can be delivered elsewhere. As Jeremy has mentioned, currently in all of our hospitals we mix up emergency and planned care, and this is one of the major reasons why we are constantly cancelling patients. We all now know that we are in the eternal winter, and we are cancelling patients in the middle of summer, which when I first came to West Wales 10 years ago just did not happen. Every patient must be prepared to have their operation as a day case, and we must help them therefore have that and be able to go home on the same day. We want to deliver safe care. It must be in the right place, at the right time, by the right person. And once you've had that operation, we need to get you home as quickly as possible and help you recover as quickly as possible so you can get back to where you want to be. Thanks.
Dr. Maynard-Jones again. I'm going to start with discussing what we did in phase 2, the design phase. And as Libby pointed out at the beginning with our timeline, following board approval in November, we entered this phase, which we've been in until now. And one of the key milestones we reached during this phase was the development of our family, Teulu Jones, a very key component of our consultation. So why did we create a family? Well, from feedback from our earlier workshops and challenge sessions and staff drop-in sessions, we felt that they were all very focused on buildings and services rather than the people that we were serving. So Teulu Jones were developed as a way to focus our options development, challenge and test through the lens of the patient experience. How do we do this? Very much backed up by prevalence data, our family design is broadly representative of our population in terms of health and social issues, reflect our demographics, and have strategically been placed in locations that would help us test the emerging models. So how have we used the Teulu to date? At our second major options development workshop, participants were asked to give a view on how family members would experience current services and systems, and then asked to describe how future models should look and feel through the eyes of the same family member. They will have a starring role during our consultation document and supporting animations, and we will use the family members to help describe what the future could look like, putting the person at the centre. The family's lives and health needs will develop over time to show their journey through the changes as they happen. So without further ado, I'm going to introduce you to the Teulu. Teulu Jones reside in Newcastle Emlyn. Mr. Alan Jones is an 80-year-old gentleman who is a retired electrician, smokes a pipe and enjoys his daily walk for the newspaper. He suffers with a cataract and has a history of ischemic heart disease and is a tablet-controlled diabetic. His wife, Mary, is 78. Her recent diagnosis of mild dementia has hit the family hard, and this, with her failing mobility, is impacting on the family dynamics, with Sinead, their 47-year-old daughter, having an increasing role in caring for her mother's needs. Sinead herself is juggling a part-time healthcare support worker role in her local district general, as well as managing the increasing needs of her mother. She also helps out with childcare for her grandson. Her husband, Rhys, who's 48, is a long-distance lorry driver with a BMI of 36 and is a heavy smoker. He lives on junk food and has long hours in the cab. His knees are giving him a lot of pain following on from his rugby days and is the reason he can't lose weight, or so he tells his wife, Sinead. Leanne, Sinead and Rhys's daughter, is 19. She still lives at home. She's currently 24 weeks pregnant and is a mother to a 3-year-old son, Ben. Leanne is doing a part-time course through her local college to become a childcare assistant, but is currently off work with pregnancy-related issues. Ben, her son, was born prematurely and has been recently diagnosed with a rare genetic condition. Gareth, who is Sinead's brother, he lives up in Talabont with his wife Aisha and their 2 sons. Gareth is a social smoker. He'd like to quit, and he also enjoys cycling with his local club most weekends.
Libby Ryan Davis. Phase 2 of the programme commenced in December 2017, as Minor mentioned, and subject to board approval today, the formal public consultation on the proposals will start today and run for 12 weeks until the 12th of July, with a consultation closing report including an external analysis of all the feedback to be presented to the board in September of this year. In determining the proposals, Phase 2 involved 5 key stages. The development of a wide range of options built on the work of Phase 1, our Discover phase that we've already talked to you about. Challenge and testing of these options through a variety of events with staff and key stakeholders. Modelling and high-level costing of options, and agreeing a set of criteria based on what we heard through the big conversation, against which we invited a range of staff and key stakeholders to score the options against. Phase 2 of the programme has been led by a core options development action group consisting of a range of clinicians who have worked intensively to consider the outputs from all of the challenge and testing events, including a SWOT analysis of the strengths, weaknesses, opportunities and threats of every option, and the modelling outputs and scoring outcomes to refine these options and propose a final long list for the executive team to consider. Throughout this process, there have been a total of over 30 options considered, resulting in Proposal A, B and C, which are under consideration today. We're firstly going to introduce these proposals to you in our consultation animated video, which we will now play.
We're your local NHS, providing care from the shores of Pembrokeshire, over the hills of Carmarthenshire, to the coast of Ceredigion. We are here for you. Most of your care is provided in the community. We have 7 community hospitals, as well as facilities caring for those with mental health and learning disability needs, and run 4 main hospitals from some of our bigger towns. From bumps and babies to older people and everyone in between, we provide all of your NHS care. We've heard your ideas on how future services should look, and we've listened to what you've had to say. Our doctors have told us that services are too fragile to meet needs now and in the future, and we must change how our services are delivered. Our population is growing. We are seeing more people who need help and support, many with complex needs. We want people to work for us so that we don't need to rely on costly temporary staff. Many of our buildings are outdated, and as technology improves, people expect better care through modern facilities. We have a budget of around 800 million, but last year spent around 50 million more. If we do not change, we're likely to see longer waiting times, more postponed operations, and services unable to meet demand. And worse still, lower safety standards, worsening health, and reduced survival rates. We want everyone to receive the same high-quality care. Based on feedback, we have developed 3 proposals which offer safe, sustainable, accessible, and kind services for the future. And during the next 12 weeks, we need to hear your views or any new ideas. We've listened to you and already decided we need to bring more care closer to your homes and communities. Many patients in our hospitals could be cared for in this way if the right services were available. In all proposals, there are 10 community hubs. Llandyfri Hospital would be a community hub with beds and a minor injuries unit. Cardigan Hospital would be a community hub without beds and with a minor injuries unit. There would be community hubs without beds on the existing South Pembrokeshire and Tenby hospital sites, as well as in Aberaeron, Crosshands, on the Delta Lakes development in Llanelli, and in the Cilchcaron development in Tregaron. A community hub with beds in Aberystwyth, and for Amman Valley, there would be a community hub without beds in our first 2 proposals, but with beds in our third. What we do need your views on is the following: locations, services needed, and who should provide care. In all proposals, Bronglais District Hospital will continue to provide services for Mid Wales. All proposals see a new hospital somewhere between Narberth and St Clair's. The Mental Health Central Assessment and Treatment Units will be located here. In this proposal, we will have a new major urgent and planned care hospital, Bronglais District General Hospital, and community hospitals on Glangwili, Prince Philip and Withybush hospital sites. This proposal would have the advantage of having a new hospital, which could help provide better care and attract new staff. but will mean some staff and patients will have further to travel to access urgent and planned care. The difference in this proposal is Prince Philip remains a local general hospital. This means there are 2 hospitals in the south of Hywel Dda, so less impact on travel times for patients in and around Llanelli, but more difficult to staff and maintain, which could mean more cancellations. In our third proposal, there would be a new urgent care hospital, a planned care hospital on the Glangwili Hospital site, Bronglais District General Hospital, Prince Philip would remain a local general hospital, and a community hospital in Withybush. This would mean less risk of planned beds being used for urgent care. However, all our current staffing challenges remain, which could mean that you may face the cancellations and delays that you do now, and less money for community services. We believe that there are many advantages with all our proposals, including improved access to urgent care and fewer cancellations for many. But they would mean further travel for some people, including those without their own transport or access to public transport. They could impact on some of the most vulnerable in society, including older people, those with disabilities, children and pregnant women. If you feel these proposals will affect you, please tell us. Before we make any decisions, we need to listen to your views and hear any new ideas. You can have your say in a number of ways. Complete a questionnaire, attend an event, write to us, phone us, or use social media. The consultation will be open from the 19th of April until the 12th of July 2018, and your views will be independently analysed. Our board will make a decision by considering all that they have heard, along with impacts and the standards we have to meet, including making sure we can afford any change. We will come back to you in the autumn to update you. Our doctors believe this is a once-in-a-lifetime opportunity to change our NHS for the better. We love our NHS just like you, and together we can make it better for our future. To find out more about our proposals, visit our website or phone us on 01554 899 056.
Dr. Maynard-Jones, and just to remind you from that video what is within and out, what in and out of the consultation scope. The following matters have been decided and are therefore not open to influence in the consultation: the delivery of services through a predominantly community model, the separation of planned and unplanned care, the delivery of an urgent care at a new urgent care hospital to serving the south of the Health Board, and the presence of Bronglais General Hospital in all proposals. However, what we do want is we welcome your views on how these services could be delivered. The following matters have not yet been decided and are open to influence during the consultation period. We do want to gather views on whether planned care should be delivered at a new purpose-built site or at a repurposed Glangwili site, whether Glangwili Hospital should become a planned care hospital or a community hospital, whether Prince Philip Hospital should be a local general hospital or a community hospital, and the availability of beds at Glangwili and Withybush as community hospitals, whether this should be associated with the reduction of beds at Amman Valley and South Pembrokeshire hospitals. We do also want to check whether there's anything else in terms of our modelling that we haven't yet thought about, and whether there are any other alternative options to delivering the services that we may not yet have considered.
Alan Williams, GP. We're going to go back now to our community plans. This is for comment and discussion. These are not part of the formal consultation process because we're fairly confident in our proposals so far, in our development of our community care, that we are on the right lines where working alongside Welsh Government plans, we're working alongside our own aims of improving community resilience, improving individual self-care, and this is happening throughout the community, throughout the Health Board already. Some clusters, some practices are a bit further ahead on this road than others, but it is happening now, and we're quite pleased to present that to you. What we're doing is really involving more members of the community, involving more patient involvement in their own plans, their own self-care, with use of social prescribing, social navigators, and really using the community that we have around us to prove that. The GP surgeries has changed out of all recognition lately in the last 5 to 10 years. Individual patients, as we've heard, are getting older, more frail. They're presenting with a complexity of diseases, and to help this really, the GPs are using a multi-agency approach. We're using more allied health professionals to help us to care for our patients rather than where we used to do it on our own. My own surgery, for example, we've got occupational therapists, physiotherapists, more nurse practitioners, more advanced nurse practitioners, and it's been rolled out really. These allied health professionals are working more and more in the community, helping us care for patients. We're also helping to prevent disease in GP surgeries, using public health data, using our own computer data. We're helping to stratify individual patient risk so we can access patients earlier on, help to prevent disease, help to treat their diseases earlier, and also help them to change their lifestyles, help them to improve their lifestyle and hopefully reduce the burden of ill health later on. Our community resources are increasing. We're using more and more work now in the community to deliver this. To improve this, we've also come up with the concept of these community hubs, which are things that we don't have at the moment. They will provide us with much more diagnostic facilities, more facilities to care for patients. So I'll hand you over now to Sean to discuss the community hubs.
So you can see in the diagram our community proposal. It's based on a number of hubs across our area. They may be existing buildings, they may be part of new developments. They'll be placed in areas where the greatest need is, according to the consultation. So what the hub's going to do, there's a new concept to most of us. They're going to provide joined-up services, and they'll be the backbone, really, of these enhanced community services that we will deliver in the future models. They'll join up and improve kind of healthcare services across our communities, and they'll be part of existing networks within GP communities and within our localities. They'll focus on care close to home, so hubs will be close to us, really, as individuals. They'll focus on wellness and prevention, and as Alan said, will focus on multi-professional approaches to patient care, so nurses, physiotherapists, pharmacists, GPs, paramedics, all working together to provide services for patients in the community. Also in the diagram, there are community hospitals, which are repurposed hospitals from existing sites. So these will all form a network of facilities to be able to support the services that are in our communities. So we've talked about that care will be closer to home. So there'll be fewer beds in hospitals, but there'll be more beds in the community. And we'll have all these services there to support these community beds. So you might probably asking, what is a community hub and what will it mean to me and what will it have in it? So it'll have a network of facilities surrounding it, but it'll have local access to services, including x-rays, blood tests possibly, and scans. So what's in a hub may vary from one place to the other depending on local need. There may be outpatient clinics in one of the hubs. You may be able to have care before your operation and after your operation, still called step-down care. You may have a minor illness or minor injury service in your local hub. And you may be able to have planned care in outpatients in these hubs. Some of the hubs may offer rehabilitation services to help people recover after a short period of illness. And there may also be assisted living in some of these hubs across the area. You'll be able to get advice for for mental health issues, and there'll be a holistic needs assessment performed on all patients. So we talk about the model across the three different proposals. The community model is the same across the three proposals. What we are consulting on in our consultation is where the location of some of these hubs might be and what type of services that some of these hubs might offer, because the locality needs may change. Some of them might have a minor injuries unit, some may not. Some may need beds and some may not. And these are some of the discussions we need to have in the public consultation. So some of these beds may need to be therapy-led, so they may not need doctors or consultants to look after patients. Nurses or other healthcare professionals may be looking after the patients in these units. And these also give us opportunities to use local funds like the cluster funds or the intermediate care fund or the transformation fund, which allow partnership working within localities so we can all work together for the greater goal. So moving ahead then, there are some examples here of some of the technologies and things we'll be using. So we have options to use telehealth and telemonitoring and big-scale public health. We've talked about prevention. We are doing a lot of work in our communities already with the prevention agenda, with pre-diabetes and preventing illnesses. And there's the concept of the community A&E, where the first place to call is not A&E at the hospital, but a virtual A&E within the community. And we need to build on pathfinders within our communities to risk stratify people according to their likelihood of being admitted to hospital and providing services to wrap around those patients. And we need to maximise our resilience building within our communities to use the services that are already present in our communities already to a greater extent.
Dr. Maynard-Jones. I'm going to take you through the hospital proposals now, as was outlined in the video. But as my colleagues to the side of me here have just described in detail our proposed community model, I won't repeat this for each of the proposals, but it is important to reiterate that the model runs through all three proposals. As well as this, you will note that Bronghais District General Hospital remains in all the proposals. This is because we recognise the relationship with our neighbouring health boards and the responsibility to support the community services in both Powys and South Gwynedd, as well as north of Hywel Dda. We want Bronghais to not only meet but exceed the ambition of the Mid Wales Collaborative. So looking at this slide now, our proposal A. In this proposal, we have 10 community hubs with no beds in Amman Valley. We have 3 community hospitals in Gwangwili, Prince Philip and Withybush. We've got 2 main hospitals, one in Bronghais at the District General Hospital and a new and urgent planned care hospital, centrally located somewhere between Narberth and St Clair's. This hospital will have all planned and specialist care centralised on one site. Moving on to proposal B. Again, the community model as previously described by my colleagues. 10 community hubs where Amman Valley does not have any beds. 2 main community hospitals in Glangwili and Withybush. And 3 main hospitals. Bronghais District General Hospital as previously described. A new urgent and planned care hospital centrally located between Narberth and St Clair's, with all planned and specialist care centralised on a single site, and a general hospital on the existing Prince Philip site in Llanelli. This would continue to provide acute medicine, have a minor injuries unit at the front door, and also continue to provide day planned care, for example the breast care unit and some day care surgery. So proposal C, once again the community model remains the same. 10 community hubs, and in proposal C, Amman Valley has beds. This is because we have 1 community hospital in Withybush. And in this model we have 4 hospitals. Bronghais District General Hospital will continue to provide services for Mid Wales. A new and urgent care hospital centrally located somewhere between Narberth and St Clair's. a planned care hospital at the existing Glangwili site in Carmarthen, and a local general hospital on the existing Prince Philip site in Llanelli.
Morning, I'm Warren Lloyd. I'm consultant psychiatrist, associate medical director and clinical director for mental health and learning disabilities. The Health Board launched the Transforming Mental Health public consultation in June of last year, and in January of this year formally considered, approved and signed off the recommendation to proceed to implementation of the new adult mental health services. The slide on your left doesn't do justice to the detail of the new model. However, it does demonstrate some key structural changes to the current model. And those structural changes include 3 24/7 community mental health centres with crisis beds, a 4th community mental health centre with extended operational hours, a single point of contact, and a centralised admissions unit in Carmarthen and a centralised admissions treatment unit in Llanelli. During the public consultation, the proposed consensus model was further shaped and informed by the public, and following the consultation, careful analysis of all the feedback has enabled us to further adapt the proposed model. And what we have now is a number of changes to the proposed model informed by our public. And these changes include the flexibility around the numbers of our crisis and hospitality beds associated with the 3 community mental health centres, the potential extension of the operational hours of the 4th community mental health centre located in Carmarthen, the consideration of how we use transport solutions more creatively. There was a very strong theme in terms of the central admissions unit in Carmarthen and the central treatment unit in Llanelli in terms of why those 2 units can't be co-located. And in terms of how do we approach a whole system working, including the single point of contact. How do we use local knowledge, intelligence, expertise, and align that with local available systems? One of the key drivers for us in mental health for the transformation program was how do we contribute and continue to challenge the stigma and discrimination associated with mental illness and learning disabilities. The Transforming Clinical Services program is an ideal opportunity to further enhance integration of services, breaking down barriers, but more importantly, provide a whole system approach in terms of accessibility of safe and sound services for anyone at point of contact with health services, whether that's for prevention, intervention, or to enable recovery. The importance of the Transforming Clinical Services and the Transforming Mental Health Program is acknowledging the opportunities and how we contribute to that as the Transforming Mental Health Program, and identifying those opportunities and therefore align those opportunities. And I want to assure the board that the Mental Health and LD Directorate has been partnered to and continue to contribute to this program of work. And there's already a number of opportunities that's been identified in terms of how we co-locate our community mental health centres with community hubs. Again, a significant opportunity for integration, but also to challenge the stigma and discrimination in our local communities in terms of mental health, but all broader in terms of those with learning disabilities. There's also opportunity to look at how we co-locate our admissions and treatment unit on a new build site. And that's fantastic news for our population using mental health services. You've heard from colleagues in terms of our estates, and they are falling apart, and there are real challenges. So this is a unique opportunity for us to look at how we deliver our services for the future for our population. And I also want to assure the board that we will, of course, give due consideration in terms of the alignment and any potential delay in some of the implementation of the Transforming Mental Health Program to ensure there's maximum opportunities and benefits for our whole population, including those with mental health and learning disabilities.
Hi, I'm Anushka Huggins, and I'm one of the subject matter experts supporting the finance group. Our proposals have been informed by the work of our enabling groups, which brought together expertise from 7 key areas. This comprised population health, demand and capacity modelling, transport, IT and digital, finance, workforce and estates.
Each of those groups have produced a technical document which provides the detail behind the proposals. We've already heard earlier on from Ros about population health, and we're now going to hear from two of our groups. Eldeg's going to take us through the finance work and Angie through the workforce.
Hi, I'm Elda Grosser, and I'm the lead of the Finance Enabling Group for the TCS programme. Our Enabling Group has undertaken work over the last few months to consider the financial viability of each proposal. We've done this by undertaking a very high-level costing analysis of each option. We have modelled the potential cost of each option based on the anticipated changes in patient flows that each of the options will generate. The different options, as Sean has mentioned, generate different bed configurations on the acute and community sites, and the costing of the options reflect this. We've costed the projected activity and facilities cost shift associated with each of these options to ascertain the impact on health board expenditure. And a consistent approach has been used for all of the options. At this point in the process, and rightly so, we don't have the level of detail required to undertake a detailed costing exercise. We don't know yet what the skill mix of staff will be in the community and hospital settings, the detail on the number of rotas and rosters that will be required, and we don't currently know what the estate footprint of the model going forward will be. All of this detailed work will be undertaken as part of the next steps following the outcome of the consultation process. What the initial modelling work confirms is that based on the information we currently have, is that the cost of all the options being considered will be less than the cost of services in 2017-18, and all can potentially deliver savings that will enable reinvestment into services that support people to live well at home. All of the options, to a certain extent, should allow the health board to reduce the costs incurred on temporary and agency staff and the maintenance of all the facilities. The next step for our group will be to work on the detailed costing analysis once a final recommendation is made on service configuration, and to explore the opportunities to access appropriate capital to implement the proposal. And there is a technical document available that provides further information on the finances and the work we've done to date.
Thank you. Angie Oliver, I'm Assistant Director of Workforce and OD. We recognise that the most important way that we deliver our care is our workforce. They are the face of our organisation, providing care and support at all points of this patient journey. So any changes to how patients access these services will impact on our teams. We see a shift to more locally based care where patients have less travel time for emergency and long-term care, and a focus on delivering care in patients' homes and in community hubs. This means our workforce will need to change. We need to build a resilient workforce with fewer professional boundaries wrapped around the patients and exploring new roles to meet patient needs. The future model sees a focus on the patient being supported in the community, with staff delivering services in community settings, reducing the need for patients and their family to travel. So what does this mean for our staff? Well, staff will see their professional boundaries change. Some staff will work more often in professional groups wrapped around the patients. This will require staff to expand and extend their roles, but this is an opportunity. As we change care models, we'll change where we deliver services. Staff from hospitals may deliver outpatients from community settings, and conversely, in-reach to hospitals to bring patients back into the community. Some staff may have to increase travel time and distance, although some will decrease. But there will be opportunities for staff to change roles and the place of work to suit. Some staff may have to work across multiple sites as part of their working role. We have great opportunities for people to extend and expand their roles, as well as developing new roles, and we are on that journey already. We'll continue to do this as part of the transformation of our workforce, and our workforce will have the opportunity to undertake these new opportunities. We'll also be able to focus on delivering care through updated technology. We are aware there are some risks with this, but we will be working with our staff throughout this process. We'll develop detailed workforce plans and recruitment plans as the services become more known to us. And we'll be working closely with the Deanery to make sure that we comply with the standards in relation to education. But there are some opportunities. We believe that the new builds will produce a much more attractive for our recruitment. We'll have better environments for our staff to work in. We'll have an increase in opportunities for new, extended and expanded roles and career advancement and development, and that will be a wide range of opportunities here. And our modernised services with our technology will enhance our working practices.
Bore da bawb, Sarah Jennings, Director of Partnerships and Corporate Services, but particularly on transforming clinical services, communications and engagement. And for the board, the recommendations in the paper really link with this next element. To put things in context, we've made a commitment as an organisation to go on a long journey, and just the way we will always work to change our services will be a continuous engagement, and one where we're often speaking to the public about and our staff about how to do things, what we should do. Today is about a very formal element of that, but only one part, the 12-week formal consultation. And the context is that we will be engaging and consulting many years into the future on the specifics of how many of our services will look. But we have a duty, not just because it's the right thing, but we have legal duties to meet through several gateways in order for the board to feel that they can today decide to go to consultation or not. And the first three of those gateways are scoping. So we have to just agree, what are we consulting on? And are we clear what that is? Have we communicated that clearly and articulated it? And secondly, does the project plan set out how we're going to consult with people? And have we gone far enough to make sure that our communication tools and our documents make that clear and give us that opportunity to do that well? The third, so today, last night we did get from the Consultation Institute, who have been quality assuring our work, a conditional good practice in everything we've done, which in the timescales should give the board some assurance that all of the documentation, the way we've approached this and how we're going to do it, and we're explaining how we do it, do meet that standard. The next three gateways will be as we go through the consultation and at the end. And we will need to assure you in September that the midpoint review has been clear, the closing date we met, and that the final report has done everything it needs to do to give you what you need to make a decision in September. But as of today, we can confirm that we have made it through the first three gateways. I think one of the really important elements that has been done is an equality impact assessment and an integrated impact assessment. But equality impact assessments aren't just done once, they're done repeatedly and continuously throughout the process of the entire journey, and particularly more than once during the consultation. But our duties, to remind you, are under the Equality Act, the Human Rights Act and the Welsh Language Measure. And we need to be really clear that when we've paid due regard to how this impacts people, particularly those that are most vulnerable in society. So there is a list there of those protected characteristics that we need to have specifically thought about as we've developed our proposals and as we continue to discuss and develop them. So attached in an appendix is the equality impact assessment. We've done one for both the plan that we have and actually for the three proposals. And I'm going to hand to Paula Evans for a couple of minutes to just describe, as she was in the group, what's emerged from the specific equality impact assessment on these three proposals.
Bore da. My name is Paula Evans. I'm the Directorate Nurse for Women and Children's Services for Hywel Dda. As Sarah's quite rightly just said, a quality impact assessment has been done and is actually shown that health issues and the need for health care services can affect anyone and everyone among the population. However, a lot of the evidence has suggested that there might be a greater and disproportionate risk for ill health and the need for care services among people with the protected characteristics that were put on the slide previously. Currently, the quality and integrated assessment that we have done has identified particular impacts in terms of travel and accessibility for those protected groups, which may be over and above what might be expected in the general population. For example, certain groups are less likely to have access to their own transport, possibly older people, and can be restricted in the mode of transport, for example, disabled people. Or perceived barriers to their use of public transport, for example, people who are transgender due to fears of stigmatisation, abuse and or violence. The quality impacts in terms of travel and accessibility may be compounded by additional elements that might put people with protected characteristics at further disadvantage. For example, living in a remote area will have implications in terms of availability and the regularity of public transport. And living on a low income will have implications in terms of the affordability of personal or public transportation. Some potential negative impacts could be mitigated or eliminated by bringing services closer to home. And there is a greater opportunity to enhance the positive impact of this. However, the consultation process may also reveal additional barriers and negative impacts previously unforeseen, which will need to be addressed as the options are further developed as part of the consultation. We do not currently have sufficient information at present to understand the full impact of the protected groups across the 3 counties. The full equality and integrated assessment will be further informed by the feedback gained over the course of the next 12-week consultation of the public consultations. This will provide opportunities to gauge the views of the public, staff and stakeholders on the best ways to deliver healthcare in the future within Hywel Dda. We will also hope to learn of the lived experiences of people with those protected characteristics to help us develop our proposals in order to provide equitable services. We have taken steps during the consultation process to ensure that the groups and individuals protected within the Equality Act 2010 have opportunity to contribute to the consultation, to have their voices heard and to influence the development of proposals to ensure that the particular needs are identified and addressed. Our approach to engage with young people is one example of this.
Thank you, Paula. And we can't just expect to publish everything today and then hope that people who want to have their say are going to find us. We have a duty to reach out and try and go to places that we haven't been before. So we've tried some new things. One example of that is reaching young people. We have a questionnaire which many people will fill out. Young people probably aren't going to fill out a questionnaire. They do things differently. And we live in a different world where for anyone who's got young people in their lives, because I know most of us in this chamber wouldn't go into that category, they live their life on their smartphones and in a different world. So we're going to show you a youth video, but we need to find some fresh approaches. We need to get this viral, almost on the black market out there. It does come with a health warning. There is a word that may offend some people, but this isn't really intended for us. This is intended for young people. So this is just an idea that we've had that we've put into practice.
Oi, you. Do you live in Carmarthenshire, Pembrokeshire or Ceredigion? If you do, listen up. This is important. Not only for you, but for your mum and dad, nan and granddad, and Auntie Betty and a bit on the side. Doctors at Hywel Dda University Health Board. Do you know what that is? No? It's the NHS of our area. They want to change things big time. After doctors, big people in suits, and people like you and me weighed up locations, facilities, geography, and important things like that. They've cut the long list down to 3 options. For the people of Ceredigion, nothing much changes. Bronglais stays the same, with a few exciting things to come in Aberaeron and Tregaron. The 3 options include a brand new super-duper hospital between Narbeth and St Clair's. This will mean radical change to Withybush, Prince Philip, Glangwili, and some community hospitals. Yeah, I did say radical. If you think it's a great idea, say so. If you think it's a really shit idea, say so. Have a rant on Facebook or invent a new hashtag on Twitter. Or if you want to be traditional, complete a questionnaire. I mean, who does that these days? Or give your grandmother a lift to a village hall and drop in at a drop-in session so she can have a good old moan. But wherever you have your say, remember to use the hashtag so your opinion is counted. Seriously, go have a look before it's too late.
So that's one of the things we're trying to do, and the comms team have put together to try and reach to young people. We are in experimental territory, so we will see how that works, and we will monitor all of the things that we're doing. So how else will we reach people? And I think, again, we have a duty to reach everywhere. So who and how, I think, is probably the question for this busy slide. But we need to try and reach all. We do know that a lot of older people really value the radio, so there'll be lots of radio adverts. Some people really will want the big fat document and will read that. And some people will want to go to the technical documents, which there are many pages to keep people, to delve down into the detail. But some people, the average attention span for a video on YouTube or Facebook is 36 seconds. So we've got our animation instead of an exec summary. We'll have videos, the ones you've seen today and others, all the way through the 12 weeks to try and bring people to look at the detail. This is a complex argument, and we need to, in simple ways, signpost people to that, but give people enough to be able to make an informed choice. So in the first 4 weeks, we have loaded up lots of traditional and non-traditional methods. We will see how they're working, and then we will adapt and do new things as we move forward. The questionnaire is important because it gives us a consistency of how we ask questions, but many people won't want to do that, and I'll explain there are many ways people can choose to get involved. But I think the main thing is we have to try and ensure everyone who wants to shape this can, and we need to listen, change, adapt, and then move on. So I think the next slide is too busy. I'm not expecting people to read it, but there are a lot of ways to reach a lot of people, and we have tried many, many tools. You will see those in the appendices, and they will be emerging. But that we have revamped the website somewhat to try and make that the go-to place for people to find the latest information, all of the tools that they'll need, all of the videos and animations, everything will be there. So for you as a board, if you need to know what the latest is, go there, it'll be there. Things will get out of date quickly as we move and develop. And the key formal documents that you are asked to sign off today as part of the formal consultation are the consultation document, the animation, which you've seen, and that really is instead of a paper executive summary, because, who reads paper anymore? The easy read version. Warren talked about people with mental health but learning disabilities. We've done an easy read version. All of these are bilingual, and the animation will have British Sign Language on it for those who need that as well. The questionnaire is an important element that needs signing off, and the technical documents. So even since last night, there will have been things we will have wanted to add to our technical documents. They will change constantly, but what we will do to make it clear what's changed is the original version as of today will be on the website, and the new version, and we will call out what changes have been made, so it is clear how we are moving and adapting, and we will do all our changes in plain view and in the open. So getting the message out is the main place is the website. There will be lots of things that aren't formal, but they will be pointing to it. We will advertise on Facebook, and very often that goes onto Instagram. We haven't run an Instagram campaign for young people because that's where most of them do their work, but we're expecting it to go underground. We will adapt as we go through this. But there's also all the traditional methods, town and community councils, posters, village halls. We have the whole spectrum, and we will have missed something, so we will adapt and add that in when we realise what we've missed. We've tried not to. So we have the first week, next week, we'll be focusing on going out to our staff and doing staff drop-ins. And then following that, we have public drop-ins across the whole of Hywel Dda. We will see how those go, and then almost certainly add more in. Where we are hearing there are groups who've got more to say than another, an area that we've identified where a particular group is affected more than another, and we need to do more work. We will take stock, we will add events, we'll focus on the gaps we've got. And these changes are so significant that even after the 12 weeks of consultation, which is a unique period, we will continue to engage, continue to be out there, and continue to listen and adapt as we go forward with pathways and how we actually do our community services. So we will signpost people in a number of ways to what we need. People can use traditional post. They can go online and fill out the questionnaire. They can go online and email. All of our documents will have quick links. If you click on them, they go to the technical documents. People can phone if they don't read and write. They can use social media. And we're asking for social media. We will be monitoring social media, but we're asking people to put a hashtag in so that we can collate all of those, sort of the sense of what is happening on social media. So that's what I put before you as a board, of our way of discharging our duties to reach out to everyone in every way we can.
So before we finish off the presentation today, we wanted to give all of our clinicians here today with us who you've heard from an opportunity to give an individual final message.
Dr. Maynard-Jones, I believe that this is a once-in-a-lifetime opportunity for our public to influence and transform our clinical services for our future generations. It's the right thing to do.
Warren Lloyd, transformation is not optional, it's a must-do to ensure the co-design and co-production of safe and sustainable services for our population.
Alan Williams, we need to use this opportunity to get health discussed in our communities. We need more health experts in our community. We need 390,000 health experts in our community.
Sean James, the models of care and proposals we've discussed with you are built by clinicians and professionals from the ground up. They're based on international evidence and what we've heard from our public, and they'll produce what we set out to achieve, which were safe, sustainable, accessible and kind services.
The wider MDT community workforce team have the experience, the skills and commitment to transform and deliver this vision of a preventative, joined-up, community-focused health service, which gives the people the voice, choice and control to do the things that matter to them in the place they choose. We welcome the once-in-a-lifetime opportunity that the TCS provides to invest and further develop the community services, including therapists, to build on what we're doing and to unleash the potential that exists. This can ensure that we can deliver safe, sustainable, accessible and kind, not only for the two patients that we've heard from today and Tylee Jones, but for every family in Hywel Dda.
Zoe Porgoff, and apologies for those who couldn't hear me earlier. We are all current and future service users. We're parents of service users, grandparents, some of us, and sons and daughters of service users. So it is in all of our interests to get this right and take this unique and exciting opportunity to ensure the sustainability of our local health and care system for the benefit of future generations. We've heard that no change is not an option. Achieving success will mean being brave, letting go of personal agendas, working across traditional boundaries, thinking and working differently, and being willing to develop and accept new models of care, working around the needs of a population collaboratively with all stakeholders involved. Whilst there's been a huge amount of work undertaken already, I'm looking forward personally to the opportunity this gives us to redesign our models and pathways, both in and outside of buildings, as that is what will realise the full potential of our ambition.
completely agree with my colleague. Change it has to happen. This is a once-in-a-lifetime opportunity. I'm not aware of any other health board or trust within the NHS that has attempted change on this scale. It is undescribable about the opportunity we've actually got at the moment. However, saying that any survey, whatever options come out, whatever decision the public make, the service that we have within Hywel Dda needs to be fit for the future generation and to match our population needs and the growing population within Hywel Dda.
Karen Jones, Senior Nurse for Neonates. Given our current challenges, there's a real need to change the way that we do deliver our services to meet the population needs. Thank you for this opportunity.
Diolch i'r bwrdd am gadael i ni ddod i siarad â chi heddi. We've heard from a variety of clinicians and interested parties about the need for change. And we've been here before. Many years ago, the then Health Secretary said no change was not an option. And what happened was that we had no change. And now we've reached a position where services are no longer fit for purpose and they're not sustainable. Now we have, as people have described, a once-in-a-lifetime, once-in-a-generation opportunity to enact those changes. And you've heard from a variety of clinicians about why we need to change, but also, and more importantly, the population of Hywel Dda deserve it.
Andrew Burns. I have very much a vested interest in these proposals as hospital director, as a practicing clinician, and also as a resident of Pembrokeshire, and at some point in the future I will retire to this area and may need access to these services. This is a very ambitious project, but I think Withybush has always been a public perception that it may close in the future, and although in these proposals it may be repurposed, many of the services will continue to remain. Some existing services will expand. New services and new roles may be added. And I think this will be good for staff, it will be good for patients. Much more care will be out in the community, which is where patients have indicated they would like to be cared for. And it will be good for me as an ongoing resident. So I do urge the board to support this in going forward. I think it promises a great future for us and very exciting.
Robin Goschel. Change is really scary. I think that's what the population, when they see these proposals, they're going to be frightened because the unknown is frightening. But change is also really, really exciting. We can be aspirational here. I touched on when I talked on my slide about pockets of really good work that is done by professionals within the health board. And we don't hear too much about that. We always hear about these challenges because that is the totality of our problem. But when things are right, when you get the right facilities with the right high-quality clinicians in the right place, things we do within Hywel Dda can be the best in Wales, if not the UK. But it's so few and far between. What these proposals present is an opportunity to make this much more widespread. That's got to be exciting. It's what the population deserve. It's what Hywel Dda deserve. And actually, we could potentially become the best in Wales and even higher if we get this right. And this is what this opportunity allows us.
Carol Llewellyn-Jones, this is an exciting time, a very exciting time, and I don't think we can afford not to do it.
Jeremy Williams. Change is difficult, and there's plenty of information in the document to inform vigorous debate, and we look forward to that to further refine the decision-making. But I do believe that this is a once-in-a-generation opportunity to improve the health and social care of the patients of Hywel Dda. We must not settle for mediocrity. We must strive for excellence, and I believe that within the pages of the TCS document is the blueprint for that excellence.
Mark Henwood, consultant surgeon. So I think I'm the last clinician, apart from Dr. Clare, to comment. So what I'll do is finish with a plea. And obviously the plea is to the board, but this is a public board, so my plea goes to the public, to our patients, to our partners, and also to our politicians. Being a health worker is a privilege, an extreme privilege, and nothing brings that privilege more home when you see the trust that people put in us, when they're very vulnerable, and their families allow us to make them and their family members better. So my plea is this: trust us. Trust us that the case for change is overwhelming, absolutely overwhelming, and the options we are presenting to you are the best chance that we have for taking Hywel Dda off the critical list. If we don't make these changes, things can only get significantly worse. So please, please trust us.
Sorry, I've lost my voice now listening to all that. I'm a bit emotional. So I just wanted to leave us before a final video clip from our staff, just to confirm the recommendations that we're making to the board today. I won't go through them all in huge detail, but you have them there within the paper and on the slide, just to be clear in terms of what we're all asking today in terms of the recommendations.
It's our NHS, have your say.
So, look, I don't know how I can follow all of that. Just to say, first of all, a massive thank you to everybody who's contributed. I know actually for many people who've contributed today, this is a new experience, a new environment, and it's brilliant to hear the authentic voice of everybody speaking. And as you can imagine, I couldn't control in any way what any of them were to say, and in fact, it was I didn't know exactly what they were all going to say. So, but I suppose what we have heard is, through all of it, a real ambition for services in this area that's way above what we're able to provide now. I think we're seeing passion, and also I'd say we're seeing urgency from everybody who's spoken. I think there would be lots of other clinicians who would have liked to have spoken today, but given what we've heard, we do need quite a lot of them out there providing service both in the community and in our hospitals, in our current service model. I was looking at the motto of Pembrokeshire County Council up there, couldn't help because it's right in front of me, ex unitate vires, and I don't speak Latin, but I looked it up, and it's out of unity comes strength, and I suppose that is pretty apt for what we've heard today from our clinicians. So the only other things I would say is that I think there's a real consensus about moving to a much more social model of health, where we focus on things that really matter to people, rather than just the sort of specialist end of the spectrum. Because in the end, what matters to people often in our communities, people living in their homes, are fairly simple things that don't require a medical specialist. And so when we design our services of the community, it won't just be contingent on the NHS. A lot of this will be about how we work with our partners. We've made an attempt to sorry, the other thing I was going to say is that not only about the social model for health, actually there's a real aspiration here to move to clinical excellence, not just to sort of meet people's expectations in Wales, but to exceed them. Certainly be the best in Wales, but to be a place where people come to look at how you run a health service. The other thing I was going to say is the family is really important to us, that how we see our services through that lens, but remembering that we haven't got everybody represented in that family. So that's why this public consultation is so important, because it's everybody's views that are important. The other thing to say, and I know I'm going to be punched in a minute to stop, is that the new urgent build, we have to remember that is in all of our options, but we need to remember that actually that would need to be the subject of a formal business case development, the formal 5-stage business case development programme. So, and we'd have to acquire the funding through that. And the questionnaire is there really for us to absolutely hear the views of each and every one of the population. We'd like to get to everybody, and there are opportunities to comment on every aspect of our health and health system. So we think we've got a run a really robust process, a really inclusive process, and we do believe we're ready to move to the next stage to approve completion of stage 1 of our consultation process and commence the stage 2 of the consultation process to go out to a 12-week period of consultation. And I look forward to the discussion with board members. Thank you very much.
I'm on. So, thank you very, very much. I mean, it doesn't really leave us much to say. I think you have covered the entirety of the business of this organisation and the challenges that this organisation has a history, and its predecessor organisations, of trying to manage. For the first time ever, you have actually given us an opportunity to go out to the public with some solutions. Now, accepting that there will be an emotional attachment to a lot of what you've said, and the other thing that I gleaned from the way that you were presenting was the emotional attachment of individuals to where you've worked for a long time, how you have faced the challenges, how you have tried to support those challenges in the best way possible. What this board commissioned was clinical organisation of care going forwards to allow us to be a sustainable health board. And what I need to ask board members are you convinced today with what you've heard in terms of the detail around our opportunity to take the recommendations forward? So I'll now open it up to questions, comments and observations. Please remember your green button and to say who you are.
Carrie Donovan from representing Health Professionals Forum. Just wanted to comment on the extent of the clinical and professional engagement here. Right from the beginning, all clinical and professions were involved in this. The Health Professionals Forum had some anxiety at first because we thought that it would be a group of managers or a group of senior clinicians developing the options and proposals. That certainly wasn't the case at all. Right from the start, the transformation team invited all clinicians. For example, the Option Development Action Group, which was a weekly group which met to develop the options, included the very senior consultant leads here, also senior nurses. There were a range of professionals as well, pharmacists, dietitians, physiotherapists. There was a criteria setting group that looked at the scoring of the options. Again, there was a range of professionals, included health scientists and also a dentist. And then there was the large workshops in December and January. 70 or 80 people were there, and I can't name all the professionals. So we were actually keeping a note of the professionals there. There was health scientists, microbiologists, physiotherapists, occupational therapists, dietitians, podiatrists, an optometrist, and again the senior consultants, senior medical consultants, senior nurses, and also GPs as well. And all those professional groups were testing cases. They looked at all the options. There were about 20 options altogether originally, and they were looking at them and critically evaluating them against what was safe and clinically doable. So in terms of the clinical engagement, it's been absolutely excellent, and all professional groups have been involved right from the start in the development of the options and filtering them down to these 3 proposals. The public can actually gauge some of the work that was done by, I think it's Appendix 23 and Appendix 29 of the bundle. There's a flavour of the amount of professionals that were involved. The consultation document doesn't actually list the amount of professionals involved in that way, and it refers to doctors, nurses and other healthcare professionals. The reason for that is because there were so many people involved, they couldn't possibly name it in the consultation document.
I know the Transformation Director is very keen to somehow capture that so we can actually name all the professional groups involved. There is a way of doing it through naming the umbrella professional groups in which all professions report to Welsh Government. So that's our doctors, nurses and midwives, therapists, health scientists, pharmacists, dentists and optometrists. So we can go forward and actually name our professional groups in that way. We look forward to that. And if that could be a board action as well, that as we move forward with modernised healthcare services, multidisciplinary working, that we actually reflect that in our board papers and our committee papers and name the professional groups rather than reverting back to more traditional ways and historical ways of naming our professional groups. Thank you.
David?
The phrase being used repeatedly was no change is not an option, and I think that is abundantly clear today. I think there's also a very compelling case for the strengthening of community services in the way that's been described. My question, I suppose my plea then, is going forward, assuming we go beyond today, that when the options are consulted upon in more detail with the public and we look at impacts, that we don't lose sight of the residual impact on the acute sites. There is some evidence, and indeed the Canterbury case study that's given in one of the appendices is one example, and there was another King's Fund report, is that although the original intention, as we, I think, have sensed, has been a sort of a seesaw effect, where we see resources moving from the acute to the community, in practice it's turned out to be additional rather than in place of. And all it does is rather than reduce capacity or services in the acute side, it's allowed us to manage the demand more effectively within what was the existing capacity. So I would just ask Phil for firstly a reassurance that we don't lose sight of that, and we don't, in solving one set of problems, create a new set. So as we go forward with the options, that we do keep an eye on the impact on the acute side, which is different clearly for the three options, whether we end up with 2, 3 or 4 sites. And also any comments that Phil has on that initially. Thanks.
Thank you, David. I think we've done a lot of modelling that's informed our documents that you'll see in the technical documents, but clearly there's a lot more modelling to be done, particularly on the shift around primary and community care and the effect on our acute hospitals. So as we build more information and eventually when we build business cases, development in the delivery phase, on whatever option we approve, that detailed modelling will need to take account, of course, of the effect on acute hospitals and the type of capacity that we will need in acute hospitals in the future. Looking at the Canterbury experience, they did reduce the demand curve, but they reduced the rise in the demand curve rather than reduce demand itself. But having said that, I think there's opportunities to go further in the future, and we will have to, given the 65% increase in over 65-year-olds that we'll have in the next 20 years. We'll need to manage that demand much more in the community and look to be even more creative than we've seen experienced across in Canterbury and other areas across the world.
Thanks, Phil. Judith? And then I've got Adam, just to give you notice, Adam.
Thank you. Judith Hardesty, Vice Chair. First of all, I would like to congratulate everybody on their contribution to the presentation, and like Libby, some of it was incredibly moving, so thank you all. I'd like to really start, I think, particularly with my role, about going back to what Alan Williams said, which is the community is the most important part. And I was really pleased to see the approach on that. But obviously, I'd like to understand, because we know there are fragilities in some parts of our primary care and community services, how we start implementing some of the change, which is, I would describe in the just do it, outside of what we are asking views for, and do we have a sense of timescale to start making some of those decisions around where resources should sit, whether that's staffing, whether that's money, and how we start implementing further those community models.
Phil?
I think, subject to board recommendations, I think we need to start right away in transforming that primary and community care model. And I'd have to say we've been on a journey. We're not on a standing start here. And when you look across our communities, you can see pockets of where those services are already in place. We are risk stratifying parts of our population and putting in care plans for people who are likely to need health services. We're just not doing it across the whole patch. There's a whole range of other things that we're doing. You've heard from Dr. Alan Williams about the multi-professional workforce in his GP surgery that his community has access to, but that's not the same across the whole of the patch. There's work on early diabetic work in Dr. James's area, which is pioneering and fantastic work, but it's not across the whole patch. And I could go on. There's all sorts of examples where you can see components of the whole system that needs to be there, but it's only in packets. The challenge for us as a board and as clinicians is how we resource that. And part of that will be making a very compelling case to Welsh Government for the announced Transformation Fund. We want to use our Integrated Care Fund money very effectively and be looking for every opportunity we can to scale up those fantastic nuggets of services that we have in patches at the moment in our community and primary care.
Thanks, Phil. Jill, did you want to come in there?
Thank you. Yes, Jill Patterson, Director of Primary Care, Community and Long-Term Care. And it is along those similar themes, really, in terms of the importance of that community and integrated primary community and social care model. And when we went out to talk to the public as part of the big conversation, what people were really telling us is that when you're going to make big change, we want absolute assurance that our primary and community services are stable. Now, we could be sitting in any one of our 3 counties today, and we know that the public are really concerned about some of the fragility and lack of sustainability of our primary care services. But what we've begun to do is make some of those changes. And following some initial scepticism, the follow-up meetings to some of our town councils and to some of our public meetings has been an increase in confidence in testing some of those new models of care. People have found themselves that they don't always need to see a doctor, that there are other practitioners and social care providers who can easily meet their needs in a different way. But we do need to scale up. And what the Parliamentary Review is challenging us to do is to actually move this at pace and to begin to invest some of those resources currently tied up within our secondary care systems into our primary care models. So that is a challenge for us because day by day we're seeing that increasing level of fragility in our primary care services. So we do need to move this forward, but we do need to take the public with us and to provide them with some confidence around the quality of care and the support and opportunity that investing in those new models will bring.
Thank you, Chair. Adam Morgan, Independent Board Member. 3 questions, if I may, Chair. The first is regarding kind of deliverability. I was just wondering if, given all 3 proposals include a new urgent and emergency care hospital, I was just wondering if that's kind of been tested with Welsh Government at the moment in terms of their appetite to support the delivering of that. Secondly, I was wondering about will there be kind of impact assessments for each of the proposals in terms of travel and the impact of the different proposals on staff, especially the kind of lower paid staff, given that they might actually have some significant impact on whether they are able to move hospitals or not. And just lastly, it's a kind of specific question around the Opinion Research Service capacity to manage kind of the likely level of consultation information that they will be able to analyse, given the quite tight timescales with regards to the end consultation report. So I'm just looking for some assurance that that can be managed within the timescales, given I know that there was quite a lot of information from the previous consultation periods that they had to wade through as well. Thank you.
Take the last first. Sarah, can you answer on the capacity issues?
there is a lot of information that we've put out, and that's going to take people time to digest. There's also going to be a lot of feedback coming back in, and that will take time to digest. And I think we've tried to allow enough time in the process to give that proper consideration, to thoroughly listen and hear what we're having back. We will have feedback from staff drop-ins next week, which we'll be hearing. We'll have feedback from the public and all of our other events. So we'll get a feel for that, and we'll adapt what else we need to do. But there will be an enormous amount of information. We have gone to ORS, an independent, because we think that should be done by someone else independent from us, so that there's an trust and an integrity in the process, but also that they are experts at doing that and can feed back to us that information. But there will be enormous amounts of information. It is a big challenge, but we believe we've done everything we can to try and do that, try and get that in time. I can answer the integrated impact assessment one, but maybe Lisa wants to do something on that as well.
In terms of the impact on the workforce, there is the workforce group which has been mentioned. There are trade union representatives on that group. And certainly part of the work of that group will be the impact on staff in terms of travel, in terms of skills. So the whole range will be looked at by professional group, pretty much the same way that we have done for our patients. So where do people currently live and how far do they travel to work, and also what assistance can we put on for staff to support them to travel. That work will develop and evolve as we start to understand the scale of the community hubs, so what facilities will be remaining, what new facilities will be in existence, and therefore what will the new facilities look like, so that we can have those very detailed conversations with all of our staff to ensure that we are able to provide them with the opportunities that they require. And we have our first Staff Partnership Forum event tomorrow.
Yes, good question. Thank you, Adam. I think that the first thing to say is we've been obviously keeping, as you would expect, Welsh Government officials briefed on the process we've been going through and the process we've had over the last 18 months. So they're clear about the direction of travel. That's not the same as any kind of formal commitment to any money, and clearly there are some significant potential capital investments involved in all of the proposals, as you say. As the Medical Director alluded to, however, when we get to the end of the consultation and we are formalising our strategy going forward, that's the point at which we'll start the more sort of traditional business case development model, which will then need to go through all of the hurdles that Welsh Government would rightly set for us.
I've got a number of people who want to contribute. Simon? Oh, sorry, Alison. Alison first, sorry.
Thank you, Chair. Alison Shapeshaft, Director of Therapies and Health Science. If I may, Chair, it's just really a couple of reflections on what I've heard today. I'd like to thank everybody who has presented, because for me what I've heard is a very clear, consistent message from a variety of clinicians across the whole multidisciplinary team, and for me that's particularly important. And being relatively new still to the organisation, what I'm really heartened about is that this is a really scary change. This is massive, this is significant, but actually the amount of not just clinical engagement, but the fact that this is clinically led and this has been driven and designed by the clinicians across the board, I think is a great testament to the staff, because they are the experts in evidence-based practice and they are the experts in what is the art of the possible, and I think that puts an awful lot of weight behind the proposals.
Thanks, Alison. I would certainly endorse what you're saying there. Simon?
Sure what happened there. Can I say on behalf, I'm sure I speak for all board members, to thank all the contributors for what an extraordinary range, comprehensive and very compelling number of presentations that we've had this morning. It's been exceptionally of high quality. What I wanted to ask was something akin to the question that Adam asked. When we're having discussions with the Welsh Government about a proposed new urgent care centre, you know, part of that discussion needs to also mention about infrastructure. You know, we've not really said a great deal about the accessibility of the hospital or the unplanned care centre, and obviously people will have to have assurance that they can be able to access it in a timely way. Sarah mentioned about the integrated impact assessment. And pages 45 to 48 mentions about possible adverse effects for people who live in
rural communities, perhaps people who live on the coast. So I just think we need to have discussions with Welsh Government about improving the road infrastructure to ensure that there is improved access to this facility, which is going to be centrally located between Narberth and St Clair's.
Thank you, Simon. Again, we're at the very early stages of this discussion, as you can imagine, and we don't want to presuppose in any way what might come out at the end of the consultation and what the final decisions will be. However, I would say that depending on what those decisions are, clearly we'll want to get into discussion with the Welsh Government about the wider infrastructure opportunities and challenges that any particular model that becomes the strategy will inform for the local population. So again, we've been keeping them informed of process and where we are, but I don't think at the stage where those sorts of things can be fully developed. I guess the assurance to the board today is that we will ensure that that's part of the conversation post the consultation phase.
John, CHC.
I'm on. Thank you, Chair. John Morgan, Chair of Hywel Dda Community Health Council. As you know, the Community Health Council is the independent statutory body that represents the interests of the public and patients. So obviously we're very interested in the presentations today. I think what I'd like to say is, whilst we have some statutory roles, if you like, in terms of the process, I'm not going to focus on those just yet, and Sam may want to come back on some of those. But we know from the public that there are good things happening in Hywel Dda Health Board, and also there are clearly some problems, and we've heard some of those this morning. I guess I would like to say that we know that using sticking plaster to try and fix these problems isn't going to be the answer, and we very much welcome the approach of a system-wide look at the health service, because that's actually the only way we're going to address these issues and have a health service that the people of Hywel Dda deserve. I think there's almost an inevitability that much of the public concern may be focused on the hospitals, and they are an important part of that network. But I think it's really important that the public do get involved with this consultation. That's the first thing to say, and please say what you want to say, but also look at the whole system as well, and the investment in the community services, which is so important, because if those don't happen, actually it puts in jeopardy the changes to the acute sector. So we welcome the ambition. In a sense, this is the easy bit. We welcome the opportunity for the public to get engaged in this process. Then we'll have to deliver, of course. But I think it's an exciting time, and our role very much at the moment is to get the public and encourage the public to get involved. So thank you for that.
Joe?
Thank you, Chair. I just wanted to make a couple of comments, if that was okay. I'm Joe Teep, Director of Operations for the Health Board. Firstly, a number of my colleagues have talked about the challenges that we face on the front line today in keeping services going. I just wanted to also say really a thanks to everyone on the front line for what we achieved today, given that there's lots of sort of talk of sort of crisis and challenge, but actually what we still achieve is amazing given that. And if we look at our sort of performance and quality and outcomes, some of our services, despite their fragile nature, as Robbie said, still deliver what I would say, having worked around the UK, best in UK services and some of the things that we offer in West Wales. So just in terms of public confidence today, I wanted to be clear that our staff do amazing things and keep the show on the road despite all the challenges, which I completely agree with. I think the second point then links to what everybody did say, and I was thinking about my emails that I get sort of weekly, and there's a daily and weekly struggle to keep things going, and I was trying to think of if there was any. I was going to read them all out, and then I thought, no, there's probably nothing that I can exclude across psychiatry, A&E, out of hours, medicine, surgery, trauma, anaesthetics, paediatrics, obstetrics, children's services, radiology, pathology, nursing for community, district nurses, acute services, all the therapies, all the health scientists, where we don't have struggles on a daily basis filling all the rotas and services we've got. And so for that alone, no change at this point is absolutely not an option, and I would fully sort of endorse everything my colleagues said.
Thank you, Joe. Paul?
Paul Newman, independent member. Clearly there's an enormous amount of work which has gone into getting us to where we've got today. I guess the sad thing is it is dwarfed by the amount of work that's yet to do, because clearly there's an enormous amount of work that we're going to have to go on over the next weeks, months and probably years ahead. In relation to the proposals which have been made, obviously two of them would include planned and scheduled care being conducted on the same site, and we've heard a lot today about the impact which unscheduled care has on our ability to deliver planned care. So it's seeking some assurance really about what work has been done to ensure that we don't have the same issues arising in the future, and how that would be addressed with two of these three plans. The second point is that there are projections of savings of circa £50 million, but that's caveated with the need for us to be investing in community services and what work has been done to cost the options which will result in delivery of more services in the community. And finally, arising out of the consultation that's going to take place, whether there's going to be any degree of weighting to the different responses which come from different groups or categories, or how is that effectively going to be sifted?
Thank you, Paul. Phil, do you want to take the first question, which was about unscheduled care?
Yeah, sure. So in option C, the split between planned and urgent emergency care is more dramatic, of course, because they're on completely different sites. So it's in some ways it's easier. Well, it is certainly easier to split those two services. We've had a lot of discussion clinically about how we could provide urgent and emergency care and planned care on a site that's different to how we do it now. And I suppose the issue is with our currently configured hospitals is it's just too easy for urgent emergency cases of people to end up on a planned care ward. And every time one person with an urgent problem ends up on a planned care bed, that means at least one operation cancelled that day, and if they're there for 2 days, that's 2 operations cancelled. But the issue is on a daily basis there's quite a number of people in planned care beds. So the discussions we've had is that when in the design of the site, we would need to architecturally separate urgent care and planned care. And we'd look at, we're looking sort of around the world for places that they've done that. And we believe it would be possible to separate them on a site, on a new site, so that you wouldn't end up with urgent care patients ending up in planned care beds. But of course, there's slightly more risk of that happening than there would be if they were on completely different sites. The issue of having them on different sites, of course, is that you have to split your workforce between the two sites. And on, I suppose, on the second question, if I may give my personal sort of take on the second question on the finances, are the savings that we've demonstrated and modelled are gross savings. They are savings that occur if you change this model. They don't, as you say, Paul, include investment in primary care to the level of which we're describing. And of course that does mean there are trade-offs, because the more cost of the hospital model, the less we will be able to spend on the primary and community care model. And that's the sort of detail that we'll need to get into in our detailed modelling as we go through this process.
Appendix 2 is the report we had from ORS on phase 1, and gives you an understanding, kind of a good blueprint for what a report would cover. But there were 409 questionnaire responses. We would be expecting many thousands, if not tens of thousands of responses. So it goes back to Adam's question about capacity. We've tried to build that in, but a questionnaire response, one response, they will all be collated based on the questionnaire questions to give us that. But it's not a vote. And actually, if someone can't read and write, they may want to give us their verbal answers. That will be equally valuable and valid. So it will be for the board to take the feedback report from ORS, which will look at, I would imagine some of our larger partners will want to write a formal letter, maybe one of the councils or, the police or the fire and rescue. That letter will have a richness in it that may go beyond the questionnaire. So those will be published as part of the report as an appendix, but the questionnaires, will give us a part of the picture. The events will give us a part of the picture. The feedback, the letters we have, the complaints, all of that will be a rich picture which will be presented to board. And it's not a binary vote or it won't be a science. It will be for the board to consider that, plus what we've heard in phase 1, plus what you've heard today, plus all the technical documents, plus all of the other work, and then make your decision in September. So what we're doing in public consultation with the questionnaire is a part of the picture, not the only picture. So there's no point people filling out the same questionnaire 10 times. It's going to be a board's judgment. Does that answer what you wanted?
It was partly about, not just volume, but different sections of the community, different interested groups, any weighting might apply to the different responses that come from those different groups. Yeah.
As I said earlier, I think with the Equality Impact Assessment, we have a duty to go further with the protected characteristic groups and vulnerable groups like carers and all the ones that the law requires us to do. Nearly 10% of our population don't read and write, so to rely on a questionnaire as our only form would be very wrong. And the most vulnerable in society, we will not weight them more, but we will go further to make the effort to make sure those people's voices are heard equally, if that makes sense. So we have a greater duty to do more to reach them. It's what they choose to do with that voice. And minorities particularly, we won't give a weighting to it, but we need to be really cognizant of who's most profoundly affected by these changes. And it always is the most vulnerable and deprived in communities, so we need to go out to those communities.
Thank you, Chair. Sam Denton, also of the Community Health Council. Just wanted to echo my colleagues' words before. I think we welcome the opportunity and we welcome the approach. We talk to lots of people and time again they do tell us about their frustrations and their concerns around the different pressures that are building on the NHS. And I think people themselves are very sure that they don't want approaches that are papering over cracks, etc. So we welcome this opportunity. I was going to seek absolute assurance from the Health Board that it will listen, it will be flexible and adaptable, not just through this consultation period, but in the coming weeks, months and years after this process. I feel that I've already got that from Sarah's answer, so that's good news. I just wanted also, though, to assure the board and the public that as a CHC, we will be listening very, very carefully to all voices, loud and quiet, to make sure that there's that quality of context coming in from us as a patient voice body as well. So I think we really welcome the approach. We really look forward to holding you to your pledge to listen, and we really look forward to bringing those public voices that we hear to you as well.
And I particularly emphasise the quiet, because I do think that there is a lot of people who have a lot to say, and they do drown out those people who actually make a real difference to the way that we deliver services. And it has to be about everybody being able to contribute. And that, along with the CHC, is what this board would be encouraging. So thank you, Sam, for making those points. Owen.
I'm Owen Cox. I'm a practicing GP and I'm chairman of Dyfed Powys LMC, which is the representative body of GPs in Mid and West Wales. I would like to echo as a practicing clinician in the area, the case for change made by all the clinicians who presented, and I think we have 3 very workable options to consider in front of us. There were a few things that are not the basis of the consultation, and one of those is investment in primary and community care. We've heard a lot said about that, but having been a clinician here for over 30 years, and lots of previous commitments to invest in primary and community care, in terms of health service investment, the percentage of investment in primary and community care has, ever since I've been here, reduced. And a challenge for the Health Board is to make this work, it needs the pre-investment in primary and community care before your new secondary care buildings are made. And you've got to do something you've never managed to do before and put your money where your mouth is.
I suppose my response, Owen, as you would expect, is about pathways, and it's about actually some of the values and the suggestions that came from our clinical colleagues this morning, which I know you subscribe to, as well as the money. It's actually having clear pathways that clearly identify where individuals from home to hospital, back to home, can identify and recognise where they are on the pathway. So I totally take on board what you're saying, but for this board, it's a whole system change, and it does require that investment rather than the sticking plaster money that we seem to be putting into the acute side. So thanks for those comments. Hilary.
Hi, I'm Hilary Jones, Chair of the Stakeholder Reference Group. I think what we've heard today is really exciting and ambitious for the Health Board and for the area where I live, and have already received treatment from the board, and hopefully will continue to do so. And I'm really looking forward to chairing the Stakeholder Reference Group next week, and would urge anybody who's a member of that group to come along and share your views with us. It's a comment really. To go alongside this ambitious plan, I just hope that the board doesn't forget that you need an efficient and effective admin system to support it, and don't develop one without the other. Thank you.
Point well made. Thank you. Un arall, cwestiwn. So, Kerry, you've got your last shot. I deliberately left you till last.
Yeah, it's a question really about, for the consultation team and communication team. It relates to the stakeholder mapping analysis, that's Appendix 4. And that's that large document. It maps the local authority as Group B stakeholders, and for that group we would provide information, we would attend meetings, and we would give them as much information as possible. I just want to ask the team whether they're satisfied with that that's the appropriate level of engagement. The reason for my question is that good healthcare in the community is what you have wrapped around that is good social care. In a previous career, I was a social worker for a local authority, a hospital social worker responsible for discharge of patients from hospital into the community. Whenever we try to reduce the day a patient's stay in hospital just by 1 day, it's quite a high-level skill required from social workers, dedication from social care staff as well, getting that package of care around the patient to maintain them in the community. So that's really the rationale for my question. And I know that, for example, in Appendix 16, where we describe our new model for community and hospital services, we state that well-being cannot be the responsibility of one organisation alone, and that we need our partners. And again, in view of the parliamentary review as well about social services and health co-producing and working together in order to get that seamless care, I wondered whether maybe some extra emphasis during the consultation on getting views from social service and care staff that could potentially inform our community models. So I'm no expert on how to run a consultation at all, so I just wondered whether you were satisfied with placing local authority into the level B stakeholder reference group.
I think actually maybe it's partly because the local authority are part of us and our team. If we had, if we were to call the champions together, local authority colleagues would be there. I think in the last 2 weeks we've probably had 7 or 8 meetings with our directors of social services colleagues. We're actually working on, and Jill referred to it, an integrated structure for health and social care. This is referring more to the elected members. So what we are doing with each of our local authorities, and you can see we're here today because we have excellent relationships with the local authorities at a range of levels. But we will be doing a workshop with each set of elected members, one with officers of the local authorities, as well as anything else they want us to do, possibly going to their full councils. We've already been to one full council. And so that's where that is in the stakeholder mapping. In terms of co-producing and co-designing, directors of social services, their teams, many people from across there are involved in this and will be going forward. So there's two elements really, and it's probably, we could probably call it out, as we'll change this as a result of this conversation, but I think it's because we see ourselves as one team already, and maybe we need to call that out a bit more. But elected members won't all be co-designing on a daily basis. They will be in a slightly different category, and we do need to do some formal things with elected members. Is that answered your question?
Missed your indication that you wanted to speak.
First of all, diolch yn fawr. I'd really like to say thank you, because it did strike me at my heart. It was very emotional, what I heard. But what I'd like to say is about the involvement of young people and children in particular, and I'm really pleased to see that. But I'd urge us not to forget the disadvantaged children, young people, especially looked after children, children that may be placed from other local authorities, so that we need to think of how to capture that information. But thank you very, very much. You answered most of my questions, because I was itching to ask about some disadvantaged children, young people. But I'd urge us not to forget the children.
Thank you, Tom. I've got one question. We've heard a lot about fragile services this morning, and that is a compelling reason to change. However, I also heard David Williams on the radio this morning talking about the length of time that it would take us for any one of these options in its entirety to be delivered. So my question is, how do we manage the fragility at an operational level now, as opposed to the work that we're going out to do on consultation on what sustainable models will take? And I ask it because I've been waiting for somebody to ask it all morning. I don't know who wants to take it.
Shall I start?
Yeah.
Yeah, I think that it's a challenging question, and actually one that the exec team was discussing yesterday, because we do, as we've heard, have a lot of fragile services that will need to keep going in the meantime. I guess the first thing to say is that whilst today is a really important moment for us, I think, as it may have been Paul said, this is the start of actually a much even more enormous challenge to get this over the line, and we've got to keep the urgency up to get this in place, because what we've heard today is we can't carry on the way we're going. However, in the short term, as a team, as a board, we do need to ensure that we continue to develop the services that we can, that we're supporting the fragile services that we know are running, and as the Director of Ops has said, the remarkable work of our front line just to do that day in, day out, I think should be noted. And that actually there are some opportunities. As we are not consulting, for example, on the future of Rhongais or the primary and community elements of this, is to ensure that we are getting on with those things in the short term, because actually they will help both now and into the future. So I think there is some room for optimism, but actually what we shouldn't do is take our foot off the accelerator in trying to get this final plan in place, because I think it is urgent now.
To page 31 of the ESPA, where the recommendations are. You've seen them. Both the teams, Libby and Sarah, have been through them. but I am going to do it again. So, are we happy as a board to approve completion of stage 1 of the consultation process, which was about the pre-consultation engagement and options development? Approve? Approve commencement of stage 2 of the consultation process, which will actually start from today for 12 weeks. Happy? Yeah. And approve the Transforming Clinical Services, a big NHS change project plan, which is inclusive of the consultation scope, the consultation plan, and all of the public consultation documents, including the videos, and I loved the young one. Everybody content? Yes. Happy to carry the recommendations. What I have to say is I'm really proud. I'm very proud of our clinical teams for presenting today such a compelling case for change. I've worked in this area 46 years, seeing as people have been banding years around, and I have never, ever in my life come across such clinical leadership that has got a direction of travel that puts the values and the hearts of our population right in the centre. So thank you very much for that. I also want to thank you for doing that and your day job, because we've had a bashing over the last 6 to 8 months, and we have kept our show on the road, and the distraction, and I know it's been in your own time that most of you have contributed, and I do recognise that. There are people in this organisation who've done nothing but this. I thank them. I thank the people who've done it as part of their day job. I thank the stakeholders and everybody who attended, even the people who thought that sharing bits of information would perhaps take us off track. I actually thank you, because it focused everybody's minds on what we were doing, and we've never had as much positivity in light of the work. People for years have thought that Hywel Dda has had challenges, and they were right. We have one opportunity to rectify those challenges and actually give us a sustainable position of health service delivery for our population. There is one group that I also want to thank, and that is the people who've actually done the day job. The directors who haven't been directly involved in this, the middle management teams who haven't been directly involved in this, but they have kept our patients safe in what we've heard this morning as some challenging times. So thank you all very much. We're now going to lunch, and then we come back. What I will say to the public and to those people who are watching it online, unfortunately we're unable to stream online this afternoon. We did feel that this was the most important part of this meeting, and so this afternoon we will be back to business as usual, and I hope we will have the microphones though. For you, those who are staying, you will be able to hear us better. So thank you all very, very much, and have a good lunch.